The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Welcome back, everyone. So now we'll be going to discuss rheumatology, allergy, and immunology after we have already discussed gastroenterology in the previous lecture. But so before we proceed with this lecture, let me first say my apologies kasi na orange yung lights sa aking room ngayon. I'm very sorry for that. Kasi hindi ko naayos na white dapat yung bulb. But anyway, so I hope na okay pa rin to sa mata nyo kahit na orange yung lights ko, okay? Sorry. So let's go to sa rheumatology, let's discuss joint disorders. Now, sa rheumatology, hindi lahat ng musculoskeletal disorders ay i-discuss, no? Because there are only a few disease entities na ulit-ulit na nadidiscuss sa na lumalabas sa PLE. Those are osteoarthritis, rheumatoid arthritis, psoriatic arthritis, and all the other topics na i-discuss natin in this set of slides. Parang ang nangyayari kasi, parang pinaikot-ikot lang nila yung questions. Like for example, for the past 2 PLEs, like March 2023, October 2022, and even March 2022, most of the questions sa rheumatology is about like rheumatoid arthritis. Nung una, like it's about the disease process, and then sa next na mga exams it's about yung treatment, and then may mga times na lumalabas yung mechanism of action ng treatment ng mga drugs. So you really have to master yung mga topics na nandito sa i-discuss natin, no? Okay. So let's start with osteoarthritis. Now, osteoarthritis is the most common type of arthritis, no? And the pathologic sine qua non means hindi pwedeng wala itong pathologic finding na to sa osteoarthritis. Like absolutely nandun siya dapat, present siya for you to say that it's really osteoarthritis, no? So the pathologic finding or the na absolutely necessary to be present, or pathologic sine qua non, is hyaline articular cartilage loss, okay? And what's particular with osteoarthritis is yung joint pain niya is activity related and in the weight bearing joints, like on the knees, no? And the morning stiffness is brief. Now I will be presenting a table in the next few slides, presenting yung comparison and contrast ng osteoarthritis to rheumatoid arthritis, okay? So that it'll be clearer to all of you. And tandaan niyo, there are 3 joints sa osteoarthritis that are usually spared. So it's O or AWE, okay? So the way na I think na nasa handouts niyo yan, no? Yung mnemonic ng O na AWE, ankle, wrist, elbow, in order to remember osteoarthritis. Now, it's also important to remember na the most potent risk factor for osteoarthritis is age. Okay? So it's not the gender, it's not kung anong weight ng patient, it's the age, the most potent risk factor, okay? So yun yung nakasulat sa Harrison's. Now, in the diagnosis of osteoarthritis, no blood tests are necessary for the workup, okay? Unless there are signs indicative of inflammation. So meaning, the diagnosis of osteoarthritis is clinical, meaning if present yung age niya and then yung signs and symptoms na symmetric, not symmetric, affects the weight bearing joints like the knees, no? It's most most probably it is osteoarthritis, and you don't need any any set of knee x-rays in order to diagnose it, no? But if ever na may x-ray na gawin sa osteoarthritis, the typical radiographic finding is joint space loss or narrowing. And there's also the presence of osteophytes or bone spurs. Now, itong osteophytes, you will not find this in, you will not find them in rheumatoid arthritis or in gout. Okay? Sa osteoarthritis nyo lang siya mababasa. And kung mapapansin niyo, kahit na siya ang kanyang suffix is thritis, meaning inflammation, yung kanyang synovial fluid, ang picture is non-inflammatory, which is ang white count ng synovial fluid is only less than 2,000 per mm cube, no? As you will see later sa rheumatoid arthritis, inflammatory yung synovial fluid niya, meaning maraming white count, no? Okay. So, ito pala yung sinabi ko kanina. Age is the most potent risk factor. And, ito yung lumabas sa previous PLE na naiinis yung mga students kasi nalilito sila kung sino daw yung PIP and sino yung ano yung pangalan nung, like yung eponym for the PIP joint hypertrophy and sa DIP joint hypertrophy. So, ito yon, Bouchard and Heberden. So, the way na mareremember nyo yan is yung mnemonic na BP, blood pressure, tsaka HD, high definition, no? So, BP is proximal interphalangeal joint hypertrophy. PIP is proximal interphalangeal. Joint hypertrophy is Bouchard. And then distal interphalangeal joint hypertrophy is Heberden. BPHD. Blood pressure, high definition. Okay? As I said, wag nyo nga kalimutan, the usually spared joints are okay? AWE, ankle, wrist, and elbow. Okay. As you will see, these are the joints. Some of the joints na affected sa osteoarthritis. This is a picture or a figure from Harrison's. And as you can see, wala ditong elbow, no? Hindi involved ang elbow, is a spared joint. Wala ring ankle, because spare joint yon. And walang wrist, because spare joint din siya. So, sabi natin BP, HD, P proximal. So, ito yung Bouchard. And then, itong distal na to, dan yan yung Heberden. Okay, yan, Heberden siya. Kasi distal siya eh. So, in terms of treatment ng osteoarthritis, the goal is to alleviate pain and to minimize the loss of physical function. There are two sets of treatments sa osteoarthritis. You can go with non-pharmacologic and pharmacologic. In terms of non-pharmacologic, it has to be activities that do not precipitate the pain. Okay? So, it could be like swimming, no? Which are, kumbaga, kasi pag running, it puts the weight, most of the weight ng patient dun on the knees, no? So, masakit yun for them. So, pwedeng yung mga ganun, mga swimming. And then, Tai Chi, kung mababasa nyo sa Harrison, sandun yun. And of course, another non-pharmacologic measure is to lose weight. Kasi, the more na mas mabigat yung patient is it puts stress on the knees, no? And, ito, pharmacologic. Yung most popular drug to treat osteoarthritis now is NSAIDs, topical or oral, no? Hindi na siya paracetamol. So kung mababasa nyo, I think sa Harrison's na yung 20th edition yung blue, and then yung I Am Plat na 3rd edition, and even I'm not quite sure about yung 4th edition ng I Am Plat, but dun sa mga editions na yung old editions, is sinasabi nila na the initial analgesic of choice for osteoarthritis is paracetamol, which is not true this time around. Okay? Kasi, based sa 21st edition ng Harrison's, na yung red one, is the most, ang lagi nang ginagamit na drug for kahit initial analgesic of choice for osteoarthritis is NSAIDs na. Okay? Hindi na siya paracetamol. Why? So this is a table from the latest na Harrison's, because it has been found that acetaminophen or paracetamol is of limited efficacy and is only conditionally recommended. So na-downgrade siya, no? Na-demote yung usefulness ng acetaminophen in patients with osteoarthritis. Okay? So, as I said, NSAIDs are the most popular drugs to treat osteoarthritic pain. And it results to, kasi ang reason nun is, kahit mag-high-dose acetaminophen or paracetamol ka, NSAIDs will still result to more improvement in pain in osteoarthritis patients. Now, this is glucosamine. This is yung mga mababasan, yung mga binebenta ng ibang mga mga medrep na supplements, mga glucosamine. Pero the evidence for that is controversial. Now, we go to rheumatoid arthritis. So, tapos na tayo osteoarthritis. Rheumatoid arthritis na tayo. It is a chronic inflammatory disease of unknown etiology, but it is autoimmune actually. So, yung kung non-symmetric si osteoarthritis, because it could happen na yung osteoarthritis ng patient is sa may right knee lang. It could happen, meaning non-symmetric siya. Whereas in rheumatoid arthritis, it's always symmetric yung polyarthritis. Like for example, both hands, no, or both shoulders, for example. So, it's always symmetric sa rheumatoid arthritis. So, the pathologic hallmarks are these ones, no? Okay, so here's a PLE recall na I think lumabas ito noong October 2022. What are the earliest involved joints in rheumatoid arthritis? So the correct answer is small joints of the hands and feet. It's actually I got it from one sa Harrison's talaga. No? Earliest involved joints are small joints of the hands and feet. Nung nakita natin kanina sa osteoarthritis, the early morning joint stiffness sa osteoarthritis lasts for only less than 30 minutes. But for rheumatoid arthritis, it lasts for more than an hour and eases with physical activity. Okay? And the frequent hallmark of rheumatoid arthritis is FTS or flexor tenosynovitis. And there's also piano key movement of the ulnar styloid. Now, ang mahalaga sa rheumatoid arthritis in terms of clinical findings is yung definition ng mga structural deformities that are found in the on the hands, no? So as you can see, marami tayong deformities na associated with rheumatoid arthritis. There's boutonniere, there's swan neck, and Z-line deformity. And you have to know yung definition. Why? Because nung March 2023, lumabas yung definition nitong mga deformities na to, no? So you have to to really understand this. So ang swan neck deformities, parang swan neck. So makikita mo dito sa picture na to, ito yung ulo ng swan. Ito yung, Okay, so ito yung ulo niya, no? And so ito, parang there's flexion of the dip and there is extension of the PIP, no? So para siyang swan neck. Okay? So, alin ba dyan yung, yung dun sa swan, alin dyan yung dip? Ito yung dip ng swan neck, and itong nandito sa, dito yung malapit sa torso ng swan, yan yung PIP na equivalent. Okay? Yan yung PIP na equivalent nung swan neck deformity. So, PIP extension, dip flexion. No? So, it is different. It's the other way around sa boutonniere deformity. So, paano nyo matatandaan nyo? Kung mari nalito ka sa swan neck deformity at boutonniere, ang pwede mong gawin is like, itry mo lang talaga magbotones. So, parang nagbobotones ka. Pag magbobotones ka, di ba nakaganon ka? So, pag nakaganon, as you can see, yung PIP niya, yung PIP ko, okay, ito yung aking PIP. Yung PIP ko is now flexed. Okay? Kasi sabi sa boutonniere deformity is flexion of the PIP. So, naka-flex yung aking PIP and yung aking dip. This one yung dip ko. Okay, sorry, hindi nyo masyadong nakikita. Pero yung dip ko is now hyperextended. Makikita nyo rin naman dito sa boutonniere deformity na to, flexed yung PIP and yung dip, DIP, is hyperextended. Okay, so para siya nagbobotones talaga, no? And then the Z-line deformity is the subluxation of the first MCP with hyperextension of the first IP. So, ito siya, yung Z. Para siyang, imagine mo, ito yung letter Z. Tapos, ito letter Z. Okay? So, subluxation of the first so, ito yung hyperextension of the first IP. Ito yon, hyperextension of the first IP. And ito yung subluxation of the first MCP. Okay? So, para siyang Z. Now, the next one is the piano key movement. Wala akong picture nun, but it's just inflammation of the ulnar styloid and tenosynovitis of the ECU causing subluxation of the distal ulna. Okay? So, rheumatoid arthritis is a systemic disease, which means na it can affect like mga organs head to toe, like ocular, leading to keratoconjunctivitis sicca, or xerostomia sa mouth, or cervical myopathy sa neurologic. So it can affect all parts of the body, no? Now, PLD recall, lumabas to no October 2022. Patient with established RA comes to with complaints of dry eyes and dry mouth. On evaluation, he's not taking any other meds aside from those prescribed for him for his RA, which whatever those are. And what is the most likely diagnosis for this patient na may RA? So the correct answer is Sjogren's syndrome. So kasi, in RA, there could be tinatawag na secondary Sjogren, which is defined by dry eyes and dry mouth in association with another connective tissue disease. In this case is RA. So mukhang may secondary Sjogren itong patient natin na to. Okay? Okay, makikita nyo rin sa oral, xerostomia siya, no? And keratoconjunctivitis sicca, so the presence of those two can lead to secondary Sjogren. Are the signs and symptoms of secondary Sjogren? Now, how do you diagnose RA? You diagnose RA by fulfilling a score, by getting a score of more than equal 6. Ibig sabihin is definite RA siya. So ito total mo lang actually yung yung itong 4 areas na to ng scoring na to. Itong ACR-ULAR na table, no? ACR-ULAR is American College of Rheumatology. ACR-ULAR is European League Against Rheumatism. So sila ang gumawa nitong scoring system na to. And if you score 6 dito sa 4 areas of joint involvement, serology, acute phase reactance, and duration of symptoms, if you get a score of more than equal 6, then it's definite RA. And remember, may dalawang 6 dito. Una is you have to fulfill a score of more than equal 6. The second is yung duration of symptoms you can get a score of 1 if the duration of symptoms is more than equal 6 weeks. Okay? Score of 6 more than equal 6 weeks. Okay? So dalawa yung 6 dito sa scoring system na to, no? Now, pag may tanong sa exam which is more specific, what is the most specific test for RA, the answer is anti-CCP antibodies. CCP is cyclic citrulinated peptide antibodies. It is more specific, 95%, than serum RF, rheumatoid factor. So aside from being more specific than aside from the fact na less specific si serum RF kaysa kay anti-CCP, which is more specific, ang serum RF is medyo mababa din yung sensitivity niya, 75 to 80%, kasi there could be some diseases or conditions that have positive RF, no? So hindi lang si rheumatoid arthritis ang pwedeng may positive na serum RF or rheumatoid factor. There could also be SLE, pwede rin magkaroon ng positive rheumatoid factor, okay? So the initial radiographic finding for rheumatoid arthritis is periarticular osteopenia. Okay? And other X-ray findings are these. So makikita nyo, wala ditong osteophytes. Okay? And ang synovial fluid analysis, sabi natin kanina sa osteoarthritis is less than 2,000 per millimeter cube. Dito, sa synovial fluid analysis ng patients with RA, it's 5,000 to 50,000, no? And the overwhelming cell type is the neutrophil. Okay? So what is the DMARD, the first choice for the treatment of early RA? The correct answer is methotrexate. Okay? Parang, I think noong March 2022 and October 2022, lumabas itong treatment of early, first choice of treatment for RA, which is methotrexate ang sagot. Okay? So, may basa nyo ni sa Harrison's yan, the emergence of methotrexate as a DMARD of choice for the treatment of early rheumatoid arthritis. But, sa pagbigay ng methotrexate in patients with rheumatoid arthritis, you have to have folic acid with it. Kasi, ang mechanism of action ng methotrexate is it has something to do with it can deplete levels of folic acid, so you have to supplement folic acid with it, no? But the problem with using methotrexate on its own is it will take a couple of weeks before mag full effect yung DMARD, which is methotrexate, which is why pag mag-i-initiate ng methotrexate, sinasabayan ng steroids or glucocorticoids, no, to control the disease before the full effect of the DMARD, which is methotrexate, but only in low to moderate doses. Now, ang isang question I think last year was di ba nga tinanong yung methotrexate as the first choice. Now, I think ang condition ng isang patient is nagme-methotrexate na siya for a couple of weeks pero may symptoms pa rin siya. So in that case, ano daw yung ibibigay mo? So actually, sinabi siya sa Harrison's na if with inadequate improvement on methotrexate alone, that's the time na you will give combination therapy such as the oral triple therapy with methotrexate, sulfasalazine, and hydroxychloroquine. Okay? So yung methotrexate, sasabayan mo na sulfasalazine and hydroxychloroquine. So in a patient with RA being treated with methotrexate, which of the following lab tests should be monitored every 12 weeks, the correct answer is creatinine. It's actually shown in this table in Harrison's na ang monitoring ng methotrexate is kasama yung creatinine, okay? Now, when the patient is on methotrexate, you have to monitor the CBC. Why? Because it can cause myelosuppression. LFTs, because it can cause hepatotoxicity. And creatinine, because, hindi nakasulat dito, but kasi ang methotrexate can lead to AKI, acute kidney injury, from crystal nephropathy and direct tubular toxicity ng methotrexate. Okay? Crystal nephropathy and direct tubular toxicity ng methotrexate. Okay? So, ang monitoring ng CBC, creatinine, and LFTs is every 2 to 3 months. Okay, here's another PLE recall na double negative. So the following drugs are not considered conventional DMARDs except, the correct answer is leflunomide. So double negative siya. So alisin mo to, cross this word out, and then cross this another word out, and then read it as if they were not present. Which of the following drugs is considered a conventional DMARD? So tinatanong niya, which is conventional DMARD? The correct answer is leflunomide. Bakit? Ano po ba itong ibang mga DMARDs na to? They are not conventional DMARDs. They are what's called biologic DMARDs. Okay? So, ang conventional DMARDs ay, apat lang, no? Meshal, MSH, MSHL, Meshal. Okay? You can think of your own mnemonic, pero okay na ako dito sa Meshal, no? Meshal is methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. Okay? As I said kanina, they exhibit a delayed onset of action of 6 to 12 weeks. Tandaan nyo yung number, 6 to 12 weeks, which is why, sabi nga natin, before the full effect of DMARDs ay mag-take effect, is nagbibigay tayo ng low to moderate doses of glucocorticoids. Now, next, which of the following biological DMARDs reduces disease activity of RA by inhibiting the co-stimulation of T cells by blocking CD28, 8086 interactions? Now, I know this is quite complicated, but ito talaga daw yung lumbas sa PLE noong October 2022 and March 2023. Basta it has something to do with the mechanism of action ng mga biologic DMARDs. So for this one, the correct answer is abatacept. Now, I know mahirap siya, but I think ang pwede nyong gawin, okay, let's just discuss this muna, no? So sa abatacept, actually, tatandaan nyo lang talaga yung kanyang mechanism of action. It inhibits co-stimulation of T cells by blocking the CD28 and CD8086 interaction. I will show you, this is a screenshot from USMLE First Aid for the USMLE Step 1 na book, the 33rd edition, the latest one for 2023. And it will show you na yung na there's an interaction between the T cell and the APC in this area. So yung APC, ito nasa left side, magpe-present siya ng antigen, no? Kasi antigen presenting cell siya, yung APC. Yung APC na yun, ipapresent siya ng antigen papunta dun sa T-cell. Tapos yun yung signal ng T-cell, which comes from the APC, yun yung signal ng T-cell to proliferate and to survive and to grow, no? Now, yung signal na yon is powered by this interaction, the CD8086 and CD28 interaction. Abatacept prevents that abatacept prevents that interaction para hindi na magpo-proliferate and magsusurvive si T-cell. And pag hindi nag-proliferate and mag-survive si T-cell, there would be no inflammation in rheumatoid arthritis. So, mababawasan yung inflammation, mababawasan yung symptoms. Okay? So, that's the role of abatacept. So, what I would advise you to do kung medyo mahirap, I know, kung na i-go through ninyo yung mga each of the biologic DMARDs na mechanism of action, you can either, number one, go through first aid for the USMLE step 1 yung 33rd edition. Kahit puntahan nyo lang yung mga meds na yon, and i-discuss naman doon. And ang maganda kasi doon sa USMLE, step 1 is siya. Sa first aid is may mga mnemonics siya, and may maganda siyang ganito na mga illustrations. Which is very useful for me at least. Kasi pag nakikita ko na ganito yung itsura niya, okay, mas madali na sa akin tanda na CD28, CD886 interaction na pinaprevent ng abatacept. It's easier for me kesa dito. Tinan mo naman to. Puro words. Diba? Ang hirap niyang tandaan. Pero kung ito, mas madali siyang tandaan for me. So, you can go through that sa very easy to read ang first aid, no? And may ganda rin naman yung explanation ng Katzong na board examination reviewer. But mas maganda for me, mas maganda yung first aid kasi may illustrations na colorful. So, mas engaging. So, next. A patient newly diagnosed with RA treated with methotrexate comes to you after 3 months. Complaining of persistent joint pains and worsening functional disability. Okay? Naka-methotrexate na daw siya, pero after 3 months of being in methotrexate, persistent in joint pain. So, it means hindi nag-work si methotrexate. Now, she currently reports that she lives with her brother na may TB in ongoing intensive phase treatment. So, baka na-expose siya doon, no? So, ano yung pwede mo daw i-add sa treatment regimen of this patient? The correct answer is sulfasalazine. Okay, why? So, why? Kasi, as you can see, yung infliximab and abatacept are biologic DMARDs. Now, sa biologic DMARDs, ito, abatacept, infliximab. So, abatacept and infliximab. So, infliximab is under this category, I think. TNF-alpha inhibitor siya, infliximab. Okay? So, before you give biologic DMARDs, you should evaluate the patient for TB. Okay? Magti-TB screenings ka sa abatacept and sa TNF-alpha inhibitors if you're gonna start din sa mga patients. Why? Kasi, itong mga biologic DMARDs na to, they may effect sila sa pwede kang magkaroon ng increased risk of bacterial infections, no? And reactivation of latent TB. Okay? Which is why sa patient na to na hindi nagwo-work yung methotrexate alone, hindi ka pwedeng mag-add na infliximab and abatacept. Kasi biologic DMARD sila, you have to it's most likely na expose siya sa kanyang brother na may active TB. So, baka mag-reactivate, mag-full-blown TB and hindi na latent TB yung meron yung patient. So, the safest one na pwede mo ibigay is sulfasalazine na hindi mo kailangan screen for TB. Okay? Okay. So, this is yung pinakita natin kanina na ang effective combinations pag hindi nag-work yung or nag-fail yung initial therapy mo with methotrexate alone is to do, so kung hindi mag-work si methotrexate alone, you can do oral triple therapy, which means you will add S and H sa M methotrexate. M methotrexate, mag-add ka ng SH, sulfasalazine hydroxychloroquine, okay, MSH, no, MSH. So, silang tatlo, again, as I said kanina, silang tatlo yung tinatawag natin na tag dito, conventional DMARDs together with leflunomide. Okay. You have to also know yung mga specific na mga side effects ng mga drugs na binibigay sa rheumatoid arthritis, such as hydroxychloroquine, which can cause irreversible retinal damage, and DMARDs, which is there are only two DMARDs that are safe to use sa mga patients na pregnant na may RA and flare. Okay, and those two drugs is hydroxychloroquine and sulfasalazine. Okay? Bakit hindi, 'di ba, apat nga yung conventional DMARDs natin, MESHL, MSHL. Dun sa MSHL na yun, S and H lang yung pwede mabigay sa pregnant. Kasi si M and si L ay teratogenic. Okay? As we said kanina, increased risk of infection, TB, is a major concern in using biologic DMARDs, yung abatacept tsaka yung infliximab. No? Okay, so this is the table I was telling you about earlier na magandang side-by-side comparison ng osteoarthritis and rheumatoid arthritis. Osteoarthritis because it is ang inaapektuhan niya is mga weight-bearing joints, which means na it will be worse for patients who are obese because more weight means more weight pressing on the knee joints. And sa osteoarthritis may Bouchard and may Heber din. Dito is sa rheumatoid arthritis, one neck boutonniere. And the morning stiffness in osteoarthritis is 30 minutes. Sa rheumatoid arthritis, 1 hour. And the mainstay of treatment for osteoarthritis is non-pharmacologic, weight loss, exercise, na non-weight bearing, non-painful for the patient. And sa mainstay of treatment for RA is DMARDs. Okay, now we go to gout, which is a most commonly it affects middle-aged to elderly men and postmenopausal women. Okay, and the early clinical manifestation of gout is acute recurrent gout flares. Okay, ito yung mga key phrases, 'di ba may mga buzzwords tayo naririnig? Meron din mga buzz phrases. Pag tinanong what is the early clinical manifestation, yan, buzz phrase yan. And dapat reflexively nade-develop niyo yung parang reflexively ninyong ina-answer to yourself na ang sagot sa early clinical manifestation of gout is acute recurrent gout flares. Okay? So tandaan niyo yan. The classic initial presentation of gout is podagra, which is pain in the first MTP joint, metatarsophalangeal joint. And here are the triggers of gout flare: purine-rich food, alcohol. Kaya nga sa mga tao na kumakain, for example, ng purine-rich food, nas nag-inom ng alak, the next day or after a few hours, magkakaroon sila ng gout flare. Now, for confirmation of the presumptive diagnosis, okay, so yun yung tanong kasi, pwede ka na mag-presumptively diagnose ng gout based on the signs and symptoms. Kung ano, may podagra, pwedeng gout yun. But in order to confirm, you have to aspirate joint fluid and see negatively birefringent, needle-shaped MSU crystals or monosodium urate crystals. Bakit kailangan yung tandaan? Ito yung findings sa gout, negatively birefringent, needle-shaped MSU crystals. Kasi there is another disease na iba yung finding. Ang tawag din is pseudo-gout. Wala tayong slide for that kasi hindi siya masyadong tinatanong. Pero baka lang itanong, sa gout is negatively birefringent needle-shaped, di ba? Sa pseudo-gout, or also known as CPPD or calcium pyrophosphate deposition disease, ang finding doon sa kanilang synovial fluid is positively birefringent, kasi di ba dito negatively. Sa pseudo-gout is positively birefringent, rhomboid-shaped calcium pyrophosphate crystals. Okay? And kung initially, ang inaapektuhan ng gout, ang classic initial presentation niya is podagra sa first MTB joint. Sa pseudo-gout, the most commonly affected joint is the knee. Okay, tandaan niyo yun. Actually, yung information na yun, if you want to fact check it, or gusto niyo, you want to read more about it, makikita niyo sa First Aid for the USMLE, no? May pseudo-gout doon, sinabi din doon na most commonly affected joint is the knee. So ito naman yung characteristic radiologic features ng gout. Cystic changes with well-defined erosions and overhanging sclerotic margins and soft tissue masses. Tandaan nyo lang yung phrase na yan. Kasi para hindi kayo malito pag ang tinanong is radiologic findings ng each of the diseases. Kasi as you can remember, sa rheumatoid arthritis, it's periarticular osteopenia. Sa osteoarthritis is hyaline cartilage loss or and osteophytes, no? Sa gout is cystic changes with well-defined erosions and overhanging sclerotic margins. So mas mahaba siya. Okay, so the most important treatment for gout is bed rest and ice pack application. The mainstay of treatment, the first line is NSAIDs, not colchicine. The first line of treatment is NSAIDs. Okay, and if it's only a single joint involvement, we can go with intra-articular steroids. Now, lumabas ito nung March 2023. Considerations for ULT drug therapy. Okay, kaya siya naka-red. There are 4 considerations for urate-lowering therapy. More than 2 acute attacks yearly, severity and the duration of flares. Kung hindi na kung pangit na yung quality of life ng patient dahil sa gout flares niya, and willingness to commit to lifelong therapy kasi lifelong yung mga urate-lowering drug therapy. Ano ba yung mga urate-lowering drug therapy? Allopurinol, and kung may sira sa kidney, you can go with febuxostat. Okay? But di ba tandaan nyo, considerations to, but it should be initiated and should not only be considered, but it should be initiated talaga with these 2 conditions. Pag may uric acid stones na, or may TOFI or chronic gouty arthritis na, no? Initiate nyo na, hindi nyo na i-consider, kumbaga. Initiate na agad. Okay, and tinanong din nung March 2023, again, numbers na naman, is yung goal urate levels sa mga patients na may gout flares. The answer is 5 to 6 milligrams per deciliter or less than 300 to 360 micromoles per liter. Okay? This is to prevent the recurrent gout flares and eliminate TOFI. Now, kung wari, bawal sa patient yung NSAIDs dahil may sira siya sa kidney, you can go with colchicine, but you have to temporarily discontinue this at the first sign of loose stools kasi that's one of the unique na side effect ng colchicine, yung diarrhea. And you should stop it at the first sign of diarrhea or loose stools. Oops. So here's our 38-year-old male with a history of psoriasis. Sought consult for joint pains including the DIPs. There's note of dactylitis, telescoping of the second left finger, hyperkeratosis and onycholysis, and nail dystrophy. So lahat yan, pag yung constellation of signs and symptoms na yan, wala na ibang diagnosis kundi PSA or psoriatic arthritis. Now, how do you differentiate it from RA? Well, ang psoriatic arthritis is seronegative, meaning hindi siya positive sa anti-CCP, which is positive in RA. CCP is, as I said, is cyclic citrullinated peptide antibodies. So negative siya doon. And often, meron siyang dip involvement, may spine involvement, and sacroiliac joint. So usually, hindi yan affected sa RA. Okay? And what are the differentials for kung isolated dip involvement na? You can go with osteoarthritis, pero yun nga is it's usually not inflammatory, as I said, and gout, but it should also involve other sites with TOFI. Okay. Now, other clues paano ma-diagnose ang psoriatic arthritis is meron siyang history of psoriasis dati, which is present in 70% of patients na may psoriatic arthritis. Most of them may personal history ng psoriasis. Okay? And may nail changes in the fingers and toes in 90%, which is katulad dun sa patient natin na may nail dystrophy. Okay? And may shortening of digits because of underlying osteolysis. Okay? Okay. So, aside from those, meron mga characteristic structural deformities din ang PSA. Okay? Which are penicillin cup deformity, marginal erosions with whiskering, marginal erosions with adjacent bony proliferation or whiskering, no? And all these other findings. So, I'll just leave this to you para basahin. Okay? Now, there's also, lumabas ito no March 2022, I think. No? Kasi, in-include ko to is October 2022 eh. So, March 2022, lumabas ito, but you'll never know. Di yung Kaspar criteria, okay, for diagnosing psoriatic arthritis. Now, medyo confusing. You have to satisfy more than equal 3 out of the 5 categories. But in order to medyo ma-memorize nyo tong Caspar criteria, tandaan nyo yung 212, no? 212. There are two wait lang. So may dalawang tungkol sa history, isang tungkol sa PE at dalawang tungkol sa labs. Dalawang tungkol sa history, which is current dactylitis or history of dactylitis recorded by a rheumatologist, and a history of psoriasis or family history of psoriasis. So dalawa, history of dactylitis, history of psoriasis. Yun yung sa history. Sa PE, may isang PE, which is psoriatic nail dystrophy observed in current PE. And then, another two para sa labs. First is negative test for RF, which is positive sa RA. Negative test for RF and radio evidence of juxta-articular new bone formation in the hand or foot. So, laboratory examination ulit, okay? 212. So, here's another case. A 26-year-old female presents with 2-month history of progressive low back pain, stiffness wakes her up from sleep. Pain is relieved by exercise, associated morning stiffness, limited spinal mobility. Okay? And sa imaging is may symmetric sacroiliitis and may anterior uveitis. The most likely diagnosis in this case is ankylosing spondylitis. Okay? So, paano na-diagnose yun? So, yung constellation of signs and symptoms ulit. Okay? May low back pain and stiffness which wakes her up from sleep. Okay? Hindi nyo yan nakita sa PSA, hindi nyo yan nakita sa RA, hindi nyo rin yan nakita sa OA. Nakita nyo lang yan ay dito sa ankylosing spondylitis. Low back pain and stiffness which wakes her up from sleep. Okay? Now, and she also has limited spinal mobility and demonstrable symmetric sacroiliitis. Wala yan sa OA, wala sa RA, wala sa gout, wala sa PSA. Okay? Dito lang yan. And may anterior uveitis. Sa ankylosing spondylitis din yan. Kasi ang makikita mo sa RA is keratoconjunctivitis sicca and xerostomia which leads to secondary Sjogren. Walang anterior uveitis doon. Okay, sa ankylosing spondylitis yun. Ang anterior uveitis. Okay? And anong histocompatibility antigen ang present sa ankylosing spondylitis? HLA-B27. And the most common extra-articular manifestation is acute anterior uveitis, which is why I included it as one of the findings. Okay? Para hindi siya ganun ka-confusing. But hindi lang ankylosing spondylitis ang may presence ng HLA-B27 na subtype, no? There are 4 actually. This is from first aid. 4 na pwedeng mag HLA-B27 positive. There's psoriatic arthritis, ankylosing spondylitis, IBD associated arthritis, and reactive arthritis. Okay. Now let's go to SLE. So this is just a figure from Harrison's. As you can see, it's an abnormal immune response. Ang SLE, it's an autoimmune disease, and the cells involved are T cells and B cells, which then eventually autoantibodies, immune complexes, yun yung nagda-damage sa mga organs. Now, how do you diagnose SLE? You have to have. Okay, we'll go back to this table later kung paano mag-diagnose ng SLE. But it's in here. Yan. Okay, so let's go first dito. As I said, it can involve multiple organ systems. And here's a PLE recall from, I think this is March 2023. What is the most common chronic dermatitis in lupus? The correct answer is discoid lupus erythematosus. Pero, diba, tinan nyo, common chronic dermatitis, discoid lupus erythematosus. But pag ang tanong is, most common acute SLE rash, that's the butterfly rash. Ulit, kung most common chronic dermatitis, it's DLE. Pero kung most common acute, kasi sabi ko kanina, chronic, most common acute SLE rash, it's butterfly rash. Okay? And you also have to remember yung characteristic ng DLE. Okay? Roughly circular, slightly raised, scaly, hyperpigmented erythematous rims with depigmented atrophic centers in which all dermal appendages are present. Okay. So, I think madidiscuss din naman ito sa patho. But you also have to be knowledgeable about the description ng DLE. Kasi again, there's a small chance na maulit yung exact phrasing na what is the most common chronic dermatitis in lupus. There's a small chance na yun na maulit. But there's a higher chance na itanong is yung kung paano siya i-describe itong description na to, pwedeng yan ang lumabas naman this time around, yung description ng DLE, no? Or, it could happen na ang lumabas is what is the most common acute SLE rash, no? So again, kasi nga, ang tanong sa PLE, kunwari, ang tinanong is si DLE. The next time around, ang itatanong is anything medyo tangentially related to DLE, which is acute, which is the most common acute SLE rash, no? It is slightly related to, it is related to SLE in general, di ba? It's in the same paragraph, no? Parang ganun. Now, the way you diagnose SLE is you have to have a total of 4, or at least 4 criteria, but you have to have at least 1 in each category. There are only 2 categories. There's the clinical and the immunologic. So you have to have 1 from here and you have to have 1 from here for a total of 4. So pwedeng 3 dito, tas dito ay 1, or pwedeng 2, 2, or pwedeng the other way around, which is 1, tas dito ay 3, no? Basta total of 4. But pwedeng fewer than 4. Pwede ka mag-diagnose sa SLE na fewer than 4, yung na-satisfy mong criteria, kapag yung renal biopsy, as you can see here, if the renal biopsy shows that it is systemic lupus. Okay? So if the renal biopsy shows that it is systemic lupus or lupus nephritis, if the renal biopsy is lupus nephritis, and then 1 lupus autoantibody is present for a total of 2, pwede mo pa rin tawagin na SLE yun. Again, renal biopsy plus 1 of these immunologic manifestations, kahit isa lang. So, a total of 2, pwede mo na sabihin SLE yun. Yun lang yung tanging exception, no? Kaya siya naka-red box dito. Okay. So, the best screening test is ANA. Okay, the high titers of SL. Now, kung ang best screening test is ANA, it is the most sensitive. But the most specific ay dalawa. There's anti-dsDNA and there is anti-Smith. So, pareho silang specific, pero nagkakaiba sila kasi si anti-dsDNA is it correlates with disease activity, nephritis, and vasculitis, pero si anti-Smith is no definite clinical correlation. So, paano tandaan yun? Anti-dsDNA correlates with disease activity. Okay? Pero sa anti-Smith is no definite clinical correlations. Okay? So, pares na may D. And another thing na kailangan yung tandaan dito is most frequently found in drug-induced lupus is anti-histone antibodies. Okay? This is another table from Harrison's. The best screening test is ANA. And another, so na-discuss natin this DNA, anti-Smith. Tandaan, ito rin, mahalaga rin to, anti-Ro and si anti-La. Pero sa kanilang dalawa, si anti-Ro and si anti-La, na ang other name is SSA and SSB, no? Si anti-Ro, yung associated with subacute cutaneous lupus and neonatal lupus with congenital heart block. Siya ang associated, si anti-Ro. Si anti-La is hindi. Okay, di ba? Wala siya dun sa kanyang table. Sa kanyang row, hindi siya dun sa kay anti-La, wala siyang association na ganun. Si anti-Ro yung may association with subacute cutaneous lupus and neonatal lupus with congenital heart block. Okay? Another thing na kailangan yung tandaan is anti-ribosomal P kasi siya yung associated with psychosis due to CNS lupus. Okay, alam ko ang pronunciation nun is psychosis pero in-emphasize ko lang yung P para matandaan nyo. Anti-ribosomal P is associated with psychosis due to CNS lupus. Okay? So meron tayong dalawang treatment options. It depends actually kung non-life-threatening or life-threatening yung SLE. Kung non-life-threatening, meaning hindi siya lupus nephritis, hindi siya pericarditis. Like for example, knee pain lang and some amount of joint pains and some amount of DLE sa skin. You can go with analgesics and antimalarials in the form of hydroxychloroquine. But if yung patient is may lupus nephritis, which is considered a life-threatening na lupus, you can go with IVPO glucocorticoids. Now, in lupus nephritis, pwede kang gumamit, aside from glucocorticoids, is cyclophosphamide and mycophenolate mofetil. So, bakit ito naka-bold? Kasi aside from tinanong dati yung mechanism of action ng abatacept in RA, tinanong yung mechanism of action ng mycophenolate mofetil, di ba? So kailangan tandaan niyo si mycophenolate mofetil is an inhibitor of IMP or inosine monophosphate and therefore of purine synthesis. So I'll show it to you. Again, mas maganda talaga pag may illustration. Again, this is from First Aid for the USMLE Step 1. So kaya maganda talaga siya. But I'm not advising you actually na basahin lahat ng USMLE Step 1 kasi there's only, I think, by the time na nire-record ko to, there's only less than 77 days before the PLE, October 20. But so baka marami na kayo masyadong inaaral. So ang pwede niyo gawin is you just go to First Aid pag nako-confuse kayo. Kahit saan man kayong handouts nag-aaral, kung ano mang handouts ang inaaral nyo, kung ano mang board review books yung inaaral nyo, pag na-confuse kayo, hanapin nyo sa First Aid. Baka may magandang illustration such as this one. So, ang purine-based production, so ano ba yung mga purine bases? We have AMP, adenosine monophosphate, and GMP, guanosine monophosphate. These are the purine bases. And they both came from this substrate which is IMP. And pero ang kailangan kasi for DNA for purine-based production, which is part of the RNA production, is ang kailangan natin is AMP and GMP. Yun ang kailangan natin, hindi IMP. Now, ang ginagawa ni mycophenolate, ito siya, is pinaprevent niya yung pagiging GMP ni IMP. Okay? It is an inhibitor of IMP. It is an inhibitor of IMP and therefore of purine synthesis. So, dito nag-a-act si mycophenolate. So, if this happens, there would be no more purine bases. There would be no nucleic acid synthesis. So, less yung T cells na mapoproduce, magpo-proliferate, magsusurvive. Less yun kasi wala silang nucleic acids to use to produce their proteins. Kung walang T cells, walang inflammation, which inflammation is the underlying pathophysiology of SLE, di ba? So, that's the reason na useful si mycophenolate mofetil in lupus nephritis. So, yun lang. So, you have to remember yung mga mechanisms of actions din. Because actually, yung hindi tatanong ang MOA sa pharma lagi eh. Nag-overlap din siya sa mga clinical sciences. So, this is just a classification of lupus nephritis. And as you can see, I'll just leave this to you para basahin. But this is important. Kaya ako ito pinakita. Kasi depende sa class ng lupus nephritis yung treatment. Okay? Kasi treatment is not recommended if it's class 1 or class 2. But aggressive immunosuppression is recommended for class 3, 4, 5, 3, 4, 5, and even 6. No? It is recommended there kasi there's a high risk for ESRD. No. 3, 4, 5, doon sa 3, 4, 5 recommended ang treatment kasi high risk for ESRD. Ang problema kasi sa 6 is wala nang residual activity. So, medyo hindi na rin masyadong effective yung mga gamot natin dyan. Kasi wala na rin masyadong natitirang functional nephrons. So, PLRICO, the following drugs are not known to induce drug-induced lupus except, so another double negative. So, you just have to cross these out. So, ang tanong dyan is, which of the following drug is known to induce drug-induced lupus? The correct answer is procainamide. Hindi ba spironolactone and rifampin din? Hindi siya spironolactone. Excuse me. Ano siya? I'll show it to you later. Sulfa drugs siya, yung S. And the rifampin is not, it doesn't cause drug-induced lupus. The anti-TB drug that causes drug-induced lupus is not rifampin. It is let me just find it, no? Where is it? I am very sorry. Nasaan yun? It is isoniazid. Ito pala, sorry. It is isoniazid. No. The anti-TB drug that can cause drug-induced lupus is isoniazid, not rifampin. Kaya hindi siya ang sagot. Okay, so marami itong mga drugs na to that can cause drug-induced lupus, but according to First Aid, ito yung mga most commonly asked na drugs that can cause drug-induced lupus, no? So the answer natin dito is procainamide. So ito si procainamide. And this is the mnemonic from first aid, which is also one of the reasons na gusto ko yung first aid kasi it gives me mnemonic so I don't have to think about it na. So, my lupus makes my hips extremely painful. You just have to go through this, no? Pero ang answer natin kanina is prokinamide. Hindi yun rifampin, it's isoniazid. It should have been my isoniazid. Okay, let's go to allergy and immunology. We have anaphylaxis. It is a life-threatening systemic allergic reaction which occurs within seconds to minutes after exposure to trigger. So if something looks like anaphylaxis pero nangyari after hours, so it's less likely to be anaphylaxis, okay? So the signs and symptoms are hypotension and hypoxia and upper and lower airway obstruction. Now, itong table for diagnosis of anaphylaxis is actually, this is not found in Harrison's. This is from up to date. This is from the World Allergy Immunization of 2011. But nilagay ko lang dito so that medyo may idea kayo kung paano i-diagnose ang anaphylaxis, which is any one of the following three. So this is 3 criteria. Any one of these ang pwede nyong ma-satisfy para masabi nyo na anaphylaxis, okay? So I'll just leave it to you para basahin on your own. As you can see dito, wala ditong tungkol sa laboratories. Why? So, puro clinical to, puro clinical findings. Why? Because the diagnosis is clinical. Yun nga, sabi ko, pag may na-satisfy ka doon sa mga clinical findings na yun, masasabi nyo na anaphylaxis siya. Okay? But there are laboratory lab tests na pwede natin gamitin which we have serum histamine and serum tryptase. But the problem with serum histamine, these lab tests are not used in PGH at least, it's not used. Kasi clinical lang naman yung diagnosis. And but serum histamine has an extremely short half-life, and serum tryptase is longer, more useful biomarker. In a patient suffering from a probable anaphylaxis, what should be done before giving epinephrine IM? So the correct answer is place the patient in supine position. Why? So as to prevent the empty ventricle syndrome. So, sige, punta muna tayo sa epinephrine. The treatment of first choice for anaphylaxis is epinephrine. Tandaan niyo yung dose. 0.3 to 0.5 ml of 1:1,000 na ang stock dose nung epi is 1 mg per ml. Paano niyo ito tatandaan? 0.3 to 0.5 ml. Parehas na odd number. 0.3, 0.5 is odd number. And meron tayong tatlong zeros. Bakit ko kailangan tandaan to? Kasi meron kasing formulation na 1:10,000, which is 4 zeros. Ito is 1:1,000, 3 zeros. Tapos 0.3 to 0.5 odd numbers, 3 zeros, 1:1,000 odd number. 1 mg per ml, another odd number, 1 mg per ml. So puro odd, no? With repeated doses at 5 to 20-minute intervals as needed for a severe reaction. Now, you have to place the patient on supine position before you give epinephrine to prevent empty ventricle syndrome. Kasi ang nangyayari dyan, ang epinephrine kasi, di ba, it stimulates alpha and beta adrenergic receptors. Nangyayari, pag hindi siya nakasupine, kung naka-upright siya, yung most of the blood will be pooling on the extremities. So, pag binigyan mo siya ng epinephrine, magpapump yung heart. Pero dahil yung blood is nasa extremities, wala kang pinapump na blood kasi wala kang venous return kasi lahat ay nasa baba. Bakit nasa baba? Kasi nga nag-vasodilation dahil nag-allergy siya. Anaphylaxis siya. So, yung blood nagpupool sa baba, walang venous return, pero nagpapump yung heart. So, walang pinapump yung heart. Kaya siya tinawag na, wala siyang blood na pinapump from the venous return. Kaya siya tinawag na empty ventricle syndrome. So, you have to place the patient on supine position so that the blood will not pool in the extremities so that may venous return so that hindi siya empty ventricle syndrome. Okay. Now, you can also give oxygen and ET intubation if progressive hypoxia develops. And yung mga iba natin nakikita na treatment for anaphylaxis, antihistamines, glucocorticoids, bronchodilators, binibigay na lang yan once the patient is hemodynamically stable. Unahin nyo muna yung epinephrine, okay? Next is APAS, okay? So, it is also an auto-antibody mediated and it's primarily in females. Okay? And there's also a sub-topic under APAS, which is CAPS or catastrophic APS. It is a life-threatening, rapidly progressive thromboembolic disease involving 3 or more organs. So for the clinical features of APS, pwedeng venous yung thrombosis and can also be arterial thrombosis. Natandaan nyo lang dito yung mga numbers and yung mga most common. The most common venous thrombosis feature of APS is 39% is DVT. More than pulmonary embolism is DVT. And the most common naman arterial thrombosis is stroke. So, tandaan ninyo, magkaano sila? Opposite. Yung isa is nasa, most common arterial thrombosis is nasa pinakataas, stroke, utak. Yung most common na venous thrombosis ng APS ay sa paa, deep venous thrombosis. Okay? Hindi sa lungs, deep venous thrombosis. So, magkabilang dulo. Magkabila, isang pinakataas, isang pinakababa. Okay? And the diagnosis of APS is at least one clinical and at least one laboratory criterion. Ito yung mga clinical and ito yung mga laboratory criterion. So, nakita nyo ba medyo similar siya sa SLE na one clinical and one laboratory, parang SLE. But sa SLE, dapat sa SLE dapat is one clinical, one laboratory for a total of 4. Pero dito is sa APS is one clinical and one laboratory lang. Okay, hindi kailangan 4. So, I'll just leave this to you para basahin. And the laboratory criteria is hindi naman katulad ng sa SLE na merong na may ANA, anti-dsDNA. Ang nandito is LA, lupus anticoagulant, ACL, anti-cardiolipin, and anti-beta-2 GPI, glycosyl phosphatidylinositol yata yung GPI antibodies. Okay? Well, actually, hindi naman yan isi-spell out sa PLE, yung anti-beta-2 GPI, no? Mahaba siya i-type. Okay, so, following the first thrombotic event, APS patients should be placed on VKAs or warfarin. VKAs is vitamin K antagonist, mga warfarin yun, for life. Okay? Now, it's different. Yung goal na INR is different kung arterial thrombosis or venous. Kung arterial thrombosis, there's a higher INR. Ang ginagamit is low-dose aspirin, 75 to 100. And kung unprovoked venous thrombosis, the INR is a little bit lower, 2 to 3 lang. Sa pregnant women with history of obstetric APS, the combination ang ginagamit is treatment with LDA and LMWH, low molecular weight heparin or enoxaparin. Enoxaparin yun. LDA is low-dose aspirin, as we said dito sa last slide, low-dose aspirin. In cases of thrombotic APS, LDA plus therapeutic LMWH, LDA, low-dose aspirin plus enoxaparin. Pero this time, it's therapeutic kasi kanina prophylactic. Ang prophylactic dose is once a day. Therapeutic dose is twice a day, Q12. No? But if it's recurrent obstetric complications, i-increase mo lang yung enoxaparin dose and give hydroxychloroquine, HCQ, or IVIG, intravenous immunoglobulin, for 5 days. Now, the treatment for CAPS consists of the following except the correct answer here is LDA. Why? So, iba ang treatment. Di ba kanina dito puro LDA tayo? Obstetric APS, LDA. Thrombotic APS, LDA. Di ba? Puro LDA tayo dyan. But it's different if it's catastrophic APS. Walang LDA doon. As indicated here sa Harrison's, ang mga patients na may CAPS or catastrophic APS should be treated with glucocorticoids, heparin, and plasma exchange or IVIG. Walang LDA, walang low dose aspirin, ha. Glucocorticoids, heparin, IVIG, plasma exchange. So the way na is GIP. GIP ang akin. Hindi ko alam kung anong meaning nun for you, pero natatandaan ko siya with GIP. Glucocorticoids, heparin. Ang mahalaga sa GIP, IVIG and plasma exchange. Mahalaga dyan, wala dyang LDA or wala dyang A. Okay? Wala dyang low dose aspirin, so hindi kayo malilito sa GIP. Okay, again, the definition of CAPS is a life-threatening, rapidly progressive thromboembolic disease involving simultaneously 3 or more organs. Yun yung treatment for CAPS. GIP. Okay, so that's all for rheumatology, immunology, and allergy. I hope you got a lot from this lecture, and I hope you read all your handouts and use first aid for the USMLE to help you with illustrations and mnemonics. Okay, so good luck everyone with your exam. God bless.